Hello, welcome. We have our amazing team of public health students, and today we are going to cover COVID and the health disparities that have been involved. So I will go ahead and hand it over to Luna. Thank you.
Hi, guys. So, like Cynthia said, we're going to talk about disparities related to the COVID-19 pandemic as well as healthcare access. And so there are a lot of racial disparities in healthcare in general. And as you can see in this graph, it really breaks down the racial disparities by race. And it shows how there's COVID deaths disproportionately affecting different groups. And as you can see, there's Black and African American groups which have the highest rates of death compared to other groups, followed by Native American, Hispanic, and Latino, and Asian. So yeah. And then here is just a definition of a health disparity. So just to shorten it a little bit, it's basically a health difference, and it's generally linked to socioeconomic or environmental disadvantage. And these health disparities are going to adversely or disproportionately affect different groups of people and their health. And as you can see, it can do with things like race, your ethnicity, your religion, your socioeconomic status, which is both your social status as well as like your economic status, gender, age, mental health, disability can be a big one, as well as someone's sexual orientation or gender identity. And this is the definition from Healthy People 2020. And so on the right side of the screen, you can see that there's different health differences between different groups of people. And these questions can kind of guide, how these disparities come along, such as how many people get a certain disease, because sometimes certain groups, like as you saw with the death rates for COVID, they're getting these diseases at a higher rate, and then higher deaths, how severe the disease is, how many people are going to have complications because of a disease. So like with COVID, for example, a lot of people of certain groups are going to have worse health outcomes because of COVID, because they're not as healthy in the first place. And that could be due to things like disparities. And it can be due to things like not having access to insurance or healthcare, or in some cases, even if you have health insurance, you could be really far away from like a doctor's office or something. And then this last question, how many people get screened for a disease? A lot of diseases, it's really important to have preventative screening. And so if you're not being preventative, you might not know that you have like pre-existing conditions, and those pre-existing conditions with COVID could make you have worse health outcomes. So these are some of the factors related to health disparities. I know we kind of went over that in the definition, but as you can see, there's race and ethnicity. As you saw on that graph, African Americans have that highest rate of death from COVID. Gender, there's just a lot of differences in gender generally. Sexual identity and orientation, that can definitely be a big thing for things like mental health. Disability status, it can be hard for someone to, get the proper care that they need, especially if they have a disability. Maybe they can't advocate for themselves, or it's a bit more difficult to get that health care. Geographical location. So, in a rural setting, you could be really far away from a doctor, and it could take, an hour to drive to a doctor, which is going to make it a lot more difficult to get that access. And then like in urban settings, there could be things like pollution, which are going to affect your health. Educational level and economic status, those also just play a huge role into your health. And then healthcare accessibility. So that can include, your access to just getting the care itself, how you are treated when you are getting that care, and just the quality of the care in general, as well as if you have access to health insurance. So here are some influences on your health. So first, I'm going to go over some protective influences. So these are influences that are going to, positively impact your health and lead to better health outcomes. So high quality education. If you look at some of the statistics on that, you're going to have a lot higher health outcomes the higher your level of education is. So like, for example, if you have a college degree, generally your levels of health on average are better than someone that never graduated high school. Nutritious food is also a really key thing. And sometimes when you have certain barriers, it can be hard to get that nutritious food. But nutritious food, it really does boost your health. It feeds your body all those important nutrients. And that's something that we really stand for here. And then decent and safe housing. If you don't have safe housing, then you could be exposed to different chemicals and stuff in your household. If you live in a more dangerous neighborhood, you might not feel safe to go for a run outside and be active because you don't feel safe in your natural environment. And then affordable, reliable public transportation. Sometimes if you can't drive or anything, then you're pretty limited to wherever you can get on public transportation. Culturally sensitive healthcare providers. There are a lot of disparities in healthcare, and so sometimes it can be difficult to get that care, that's culturally sensitive for your group. And then health insurance is a big one. A lot of people don't have health insurance, which means they're not necessarily getting the care that they need because they just truly can't afford it. And so that's obviously going to affect your health. And then clean water and non-polluted air. So having that, those clean options are definitely great for your health, as pollution in both water and the air is going to affect you negatively. And then, so why are these important? These influences can determine how someone's health outcomes will occur. And a lack of any of these can basically lead to a disproportionate amount of negative health outcomes. So basically, if you don't have these, you're going to have worse health outcomes compared to someone that may have all of these available for them. And so now we're going to move on to what are racial disparities, and Indu is going to take over for that.
Talking about the health disparities and how it has affected the health factors and health outcomes of people. So, like when we look at it, like when we consider life, we expect the health outcome to be like having a proper health, living without diseases, or even if you have a disease, like you just come out of it like with good health care, quality health care, and you live a very healthy life. So we just always like measure life with means of life expectancy. So usually nations, they compare their life expectancies over decades and also like globally across with other countries to determine like whether they have proper health coverage, proper health outcomes and all that. So when we check the life expectancy from 2006 to 2018, so the rankings are from 2010 to 2020, but still like we have the figures from 2006 to 2018, which like says there is an increase in life expectancy from 78 to 79, from 2006 to 2018, but still like when we see, it's not the same across all the ethnic and the racial groups. If you see the national value, that's a dotted blue line, which is the national thing, which is averaging around 76 to 78 something. And if you see the white population have got that. So when you check the other racial groups, it's around the American Indian, Alaska Native, the Asian Pacific Islander. They are yet to catch up that. They are actually below that level. The blue and the yellow lines, they are actually below that levels, and we can see like they are not improving much, and the health outcomes and the life expectancy is not the same across all the racial and ethnic groups. So to just know the health outcomes and health factors, we had some questions discussed by Luna before. But for health outcomes and health factors, we have two important questions that we have. So health outcome is defined by how healthy are the community members in a county. And the health factors are about what are the opportunities for the community members to be healthy in the future. So the social and economic factors, as we have discussed before, the education and the low socioeconomic status and belonging to certain communities, minority communities, it's like predisposing you to more diseases, especially COVID. So the government has devised the model of population health to determine the overall county health. So every year they just release a county health rankings, and so we get to know like what counties are doing good in health outcomes, what counties are not doing good, and how can we like fill in these gaps. So when we take this figure, so it says about like how we calculate the health outcome through the length of life and quality of life, The health factors through the health behaviors, clinical care, socioeconomic factors, and physical environment. So the policies and programs of the government are based on these county rankings, and they focus on the least healthy counties and like help them achieve good health. When we see the disparities in healthcare, so what are these health disparities coming from? We claim that US has got the best of healthcare facilities and technological advances in the world. But where do we lack? We lack, because we have seen already the life expectancy is not equally improving with all the racial and ethnic groups. So certain populations such as minorities and groups of low socioeconomic status, they have these inequities in health outcome. So some examples can be the black infant mortality rate is 2.5 times that of the white infants, and the life expectancy for black individuals is about 10 times lesser than the white counterparts, and the Latinos and Native Americans are 30% more likely to have diabetes. These are certain measures to understand how the disparities are affecting the health of these racial and ethnic minorities. So why does this happen? We should know, when there is a problem in the society, we should understand why this is happening. So it could be due to the high cost of healthcare and healthcare insurance. Yes, we understand, the healthcare and health insurance is costing a lot, for people, and everyone cannot afford it. And being uninsured, what happens to people? It leads to less preventative care. They cannot go to good hospitals. They cannot get the claims, so they are reluctant to go to hospitals, and they are trying to manage that within themselves. Think about an infection. Like a person is not going to the hospital because he cannot treat his infection. He's going to spread that to everyone in his family, and in the society. So being uninsured is a very high risk in a society. And aside from the high cost, disparities can also be due to the lack of trust. People really don't trust because they have economic deprivation, they have educational deprivation, and they feel like they are not respected in the society. So like they don't have trust in your system, and they have low health literacy and language barriers also, and they have trouble accessing care. So when we look at all these disparities, I want to understand if there is any statistics that can help us. Can Ruchika enlighten us on this?
Yeah, so if we see at all the stats, we can see that the highest percentage of COVID-19 cases are among non Hispanic white people. However, racial and ethnic minority groups are disproportionately represented among COVID 19 cases. The percent of cases for racial and ethnic minority groups are higher than the percentage of these populations within the total US population. Comparing the percentage of cases and the percent of the total US population by race and ethnicity provides an indication of the disparities. So, among laboratory confirmed COVID 19 associated hospitalized cases, more than 90% have information on race and ethnicity. There are differences in age adjusted hospitalization rates by race and ethnicity. So we can see here that the American Indian or Alaskan people they have more cases and more hospitalization as well as more death as compared to Asian or non-Hispanic, then Black one or Hispanic or Latino. So the way that varies, it shows us that all these things are affecting, including social economic status, access to healthcare, and exposure to the virus related to occupation that is among frontline essential and critical infrastructure workers. Then, data on race and ethnicity for more than 90% of people who died from COVID 19 reveal that the percent of Hispanic or Latino, non Hispanic Black, and non Hispanic American Indian or Alaska Native people who have died from COVID 19 is higher than the percent of these racial and ethnic groups among the total US population. This disparity is even greater when the percentage are age standardized. Hispanic or Latino, non Hispanic Black, and non Hispanic American Indian or Alaska Native people also have a disproportionate burden of COVID 19 death among specific age group across the lifespan children, youth, adults, and older adults. Now, these are the factors which lead to racial and ethnic minority groups being disproportionately affected by COVID 19. One is multi generational housing. That means they are sharing a closer space. Then, lack of access to quality health care. health insurance, or culturally competent providers. This can lead to people waiting to get care until their condition has worsened. Many of these individuals are essential workers. That means they cannot work from home, they don't have paid sick days, they are getting paid hourly on the hourly basis, and they cannot work remotely. So they have to be there for their job, and that is the major reason that they are getting infected all the time. Then lower quality education leads to low literacy and lower paying jobs and less job security. Low income levels can lead to individuals using public transportation, where definitely on public transportation, the chance of getting COVID is much higher than when you are using your own transportation, and working jobs where there's higher level of exposures. Then lack of healthy food, because they have not, like, they don't have the proper knowledge. That's why they don't have a balanced diet, and that can definitely increase your chances of getting COVID, because their immunity is low, their bodies are not that strong. That's the reason. Then marginalized groups already have a higher risk of conditions such as diabetes, obesity, and hypertension, and these chronic conditions serve as commodities for COVID-19. Can we move on to the next slide? Okay, thank you so much. So, racial bias in healthcare during COVID 19, more likely to, because they are not having access to testing. Since we were discussing about this thing that they don't have health insurance, that is why they don't have access to testing. Then they live in high density area where the population is more, and they're living in closed communities, and they're getting more infection rate is higher there because they're interacting more with their fellow people there. Then be exposed to pollution. Of course, in cities we can see that there's a lot of pollution there, and the pollution level is a major factor causing COVID, because people might have some allergies or lung problems, and that always increases the chance of having COVID. Having a pre-existing condition like diabetes, hypertension, they definitely make you prone to catching COVID easier than the person who is healthy and trying to maintain a healthier lifestyle. And if they are an essential worker, then definitely that increases their chance for catching COVID. So on top of this, that's a racial bias in healthcare. Now, disparities in health coverage. American Indians, Alaskan Natives, and Hispanic have only 68% health coverage. Now, we can see in the graph that percentage of Americans with health coverage by race are whites are having 88% of health coverage. That is, most of the time they are covered. And if they have any problem, they can definitely reach out to the doctor, and they can get treated faster than anybody else. But Asian American, the percentage is little lower, 82%, but still, like, they are managing themselves. Then come Native Hawaiian or other Pacific Highlander, they have 80%. Only 80% of them have the health coverage. So rest 20%, they will be ones who will be suffering more. Then African Americans or blacks, they are also having 79%, Hispanics, and then American Indian and Alaska Natives have only 68% of health coverage. So this shows us all the disparities which the people are facing on the basis of their race. Uh,
So let's move on to the disparities by the occupation. So as Ruchika has clearly covered us how much races have been affected without the um, health insurance coverage and everything. So we see that about 60% of the healthcare workers are white, and 40 people of color, including 16% are black and 13% who are Hispanic and 7 who are Asian. So, which can be clearly seen in the graph, which is given site in the site. So, you see a lot of people here accumulate to the healthcare workers, in which a larger proportion is the white community. So, they're about 60% here, and the others are almost only 40% here. So, and when we look at the other occupation, we see slight differences in the other ratios, but we see a lot of them are majorly white here, and with the other communities with accumulating about 40% here. So let's see how they have got the insurance and how they've been covered. So let's look onto the statistics that have been given by CDC. It is confirmed that almost half of the cases for the healthcare professionals were 53%, of which the color were 26% black, and 12 were Hispanic, and 9 who were Asian. So just a little bit of calculation with the previous slide, which we had 68% of the Hispanic people who have been covered by the healthcare insurance. So we see 40% of them. So for example, we take 100 people. So out of which 40 people are the minorities of color, including all the ratios. So you can see that almost you'd have 68% of it, which is only 27 people. So that is the only thing in which says that we have not been actually covered by all the other health insurance things, which is a quite a sad event, which is to be definitely said. So that is what is the disparities that we have to discuss by occupation. So we should be looking into all the other categories so that we would be covering them too. So according to the actual COVID condition, so are we actually ready for the second surge? So what are the actual necessary things that we can actually do so that we are actually ready for the second surge? Is it something that we have been overlooking in the past period, and can something be actually done? So there are some points that we have just brainstormed, and we have just got some points, and where we see that the personal protection equipment, which is the most important equipment for almost everyone serving. So it is not just the people who are in the healthcare industry who has to be given every protection, but it is also to be given to all other professionals who have been meeting with so many people in their day to day life. They definitely includes grocery cashiers, bus drivers, nursing home attendants, because they definitely use public transportation, and they travel to a lot of places, they meet a lot of people. So I don't know, like even in the initial stages of the pandemic, we saw a lot of people working there in the grocery stores too, but how many of them did have a PPE, right? So that was actually not available. So it would be definitely helpful if we get them to all the necessary workers, and it will be a great effort so that they would be covered in case if they don't have health insurance. This will actually be a life-saving equipment for them. So this is something that we have to actually take care for the second surge. And the country, can we go to the previous slide? Yeah. So, and there have been all another issue of not having enough ventilators. So, in which doctors sometimes have to, and they have faced situations in which they have to choose between patients, so that they split the ventilators for two people, which is actually a very disheartening situation in which you sometimes have to estimate the percentage of the chance of survival and give it to some people who is actually ready to survive. Life is always life, so it is never to be divided among people. So if they have all the rights to um, uh, get the equipment and get the ventilator and get all the facilities, everybody has a right to get it. So it will be good if we are well equipped, and we are ready to accommodate even a number of patients coming to the hospital. So we have to be giving them all the necessary treatments and facilities, because everyone is important and we have to take care of everybody. So that is what is the healthcare industry has been taking care of us. So we have to also help them, we also have to equip them with all the necessary facilities. So moving on to the next phase, we also have the vaccine rollouts, and I'm really happy to see a lot of people getting vaccine, and people are, and especially the people who are in the older phase of life, they have been getting all the vaccines, and it's a really a welcoming thing, because I'm just happy to see a lot of happy faces. So it'll be really good if we have everything equally given to everybody without any disparity. I just hope everything just equalizes and everything goes out in a smooth fashion, so that everyone is treated equally and everyone has the opportunity to get the vaccine. So this is definitely possible if we have a little more investment in the public health, so that will be really helpful. So that is how we can just prepare ourselves for the second surge. So let's go into the Affordable Care Act. So yes, it has been with us for 10 years. So it's quite an exciting thing because it is definitely helping a lot of communities to overcome and be accessible to all the health insurance. So it is definitely something uh, to be welcomed, and everybody should be aware of it. So what has happened since the first enrollment period, and how many people have been gaining coverage over it? So we see about 16.4 million people have gained coverage, which is something an enormous number, because out of people who have not been using, and suddenly if you get a lot of people getting into the health insurance, it definitely makes them feel safe. So even it is not just about COVID. So this was just a pandemic which was just out of blue. It just came to us. But before the COVID period also, this has helped a lot of people, and it has helped them to just be happy, and uh, they were just they were leading a stressful life because of having the health coverage, because it has helped them, and they had no worries because of it. So I'm really happy to see the number here. And we see a 4.2 million Hispanic community has gained coverage, which is something really a commendable statistics here. And we see 2.3 million African Americans have gained coverage. So this is something to be really welcome, because this act is something that you have to definitely give your household income and the size of your family, so that in case if it is larger, if you have a larger family and you have a lower income rate, the subsidized health coverage that you get, the percentage of taxes are definitely very low for them. And that is what has been a welcoming fact, in which they were able to take it, and so many people have gained out of it. So this is something a very a very welcoming act for everyone, and this is to be continued. And I'm happy that so many people have been gaining out of it, and hope it actually continues. So yeah, so next let's move on to something uh, which is actually to be looked on. So that is the rural areas. So yes, we all know we have been cities, and we have been doing a really great job, and we have been following all the other guidelines, and and all the social distancing and everything. So we have all the healthcare access to. We have a lot of hospitals also covering us. So what is the healthcare access what is actually there in the rural areas? So we see, as of December 2018, we have 95 rural hospitals have closed in 2010. So is it really nice? So I don't know. I really can't say something about it, because we need to have hospitals everywhere, and that is something which is lacking. So it's not something like you have a grocery store or some other stores nearby. This is something a mandatory basic need for every human. And what were the actual reason to close it? So we see that they were definitely failing to recover from the recession. Yes, we have seen a lot of companies close too. So it is definitely hitting the hospitals too. So are they ready to take the challenge, and is the government actually supporting them? So that's a big question mark. So that has been a reason. And the population demographic trends, yes, sometimes you don't have people coming in, coming out, so they don't have access to that. So yes, that is definitely a reason. So in which population plays a major role. So in which you can have instant, if you have a good measure of the demographic area. So according to the area, if you have 28 people just living in the area, you can have one clinic. So you may not need 5 to 6 clinics. So at least that one clinic should be there. So that has to be assessed, and that should be there. And we also have financial struggles. Everywhere we don't have government hospitals or government aided hospitals or something. There are private firms, private hospitals who are supporting them. So if they are in a financial struggle, and they will not be able to with what face the challenge. So that is also another reason. And we also have decreased demand for inpatient services. So yes, sometimes you have to take them to uh, for to other places for scan or some other surgery or some purpose. So that also has, it has been by word, it just spreads. So you just say some to someone else saying, yeah, this hospital doesn't have that facility, so we can just move on to the other one. So even to the initial stage, you don't go to the hospital, so they don't have the other services. So eventually patients coming in also decreases. So that is also another reason that we have a disparity here. So what are the health disparities according to diseases and death? So, compared to the Americans in urban areas, rural Americans are more likely to die from heart disease, cancer, unintentional injury, chronic lower respiratory disease, and strokes. So, these are something which is uh, a very and these are alarming rates which we actually don't realize. So it is something that we all are in the urban areas, we don't look upon what is actually going on in the rural areas. So if they are given a good access to hospitals and other healthcare facilities, if they go to some other healthcare campaigns or something, so they would be definitely treating with all the other things. They would go on to uh, get themselves treated with everything, and that will be good.
Yeah,
So
sure. Yeah, sure, Vinotha. Like, I mean, like we should all be like, aware of what's happening everywhere, because the rural areas are the people like who are giving us the food. I mean, the agriculture is most predominant in the rural areas.
exactly.
Yeah, they give us a lot, and so like like it is our responsibility to take care of everyone also. So like like it's really disheartening to see hospitals are closing and quite number of diseases and death affecting the rural areas. It's really, really disheartening. Thank you so much, Vinotha. So, when we go on with the key disparities and challenges that remain ahead of us, I mean, we should know, like, like what challenges that's remaining ahead of us. So, when we see some worsening factors, it's even more disheartening to see these factors because, they are still worsening. How much our technological advances we make, how much our economically we improve, we still have all these healthcare problems with us. So, see, the first of all, the children poverty, where is it? I mean, like it started from 13% in 2006 or something. It stands at 18% now, and it's not at all changing. And children in poverty, I mean, I cannot believe this. Like at least adults, we struggle to thrive somehow. But how come children they cannot manage when they are going to be in poverty? They are going to be in disease. They are not going to have proper education. I cannot believe of a future without children. So children poverty is something alarming here. And also look at the income inequality, how home ownership, long commute, people commute a lot these days because they cannot afford to live in urban places, so they live in rural areas and they have to have a long commute to go to their work. And look at adult obesity, it's also worsening. And sexually transmitted infections, yes, equally they are increasing. So when there is no meaningful progress in the rates of children living in poverty and the income inequality is rising, and home ownership and everything, like I mean adult obesity, everything is worsening. Like we know what sort of world we are living, and we have to do a lot of work to just dissipate these disparities. And we have to help people, we have to help our fellow human beings in improving the health of ourselves and everyone. So when what remains a formidable barrier to the health of our nation today and in the future? So can I ask Luna, what's that barrier that's affecting us?
Um, I would say child poverty is definitely a big barrier that we've been facing. Some counties have showed, that they've been reducing child poverty. but many counties still face this, and this child poverty is definitely, related to racial inequalities. Um, and, child poverty is definitely something that, is a cycle in many cases. So in many cases, people that grow up in poverty, they end up, having trouble getting education, which means they're going to, end up in that minimum wage job, which means they're going to, have their children who also might grow up in poverty. So it's kind of just a cycle that can be super dangerous to groups. And so I think it's something that we really need to address from the start, because if you give these children these opportunities, they're going to be able to go so much further, in their life if they have all their needs met. And so I think we need to definitely address that for
Yeah,
the health of our nation.
yeah, I agree, Luna. Thank you so much.
Yeah, thank you.
And do the least healthy counties correlate with the health disparities? Yeah, a very big yes. Not all the groups of people face the same level of progress in health factors and outcomes. That means all the races and ethnicities have progressed in different pattern, in a different way. Counties that are among the least healthy in the 2020 rankings are a part of the Deep South, Appalachia, and tribal lands. These counties represent all community types but largely rural. So we can see that all these counties fall in the rural areas where people have less access to health care and they are not going for their physical yearly checkups. That is why they are suffering a lot. These communities face barriers to opportunities as well because they are in the rural areas and they don't have much access to all the good things that the city life gives you. These counties have higher rates of poverty, uninsurance, and unemployment than the rest of the nation's county because definitely they don't have that many opportunities as the city offers them. So the rural areas, the people, they don't have much knowledge about the insurance. And as we have seen in the previous slides, that the hospitals have been closed in these areas, so it's very difficult for them to travel to a long distance to get to hospitals also, and unemployment rates are an all-time high. We can see in 2020 that has bring a lot of changes. So yeah.
So now that we've understood really what health disparities are and who the vulnerable populations are, it's important to understand
I think somebody went on mute there by accident.
Yeah, Lena.
Oh, sorry, can you hear me now? Sorry. So now that we've understand really the health disparities and what the vulnerable populations are, it's really important to understand what the next steps are, and more importantly, understanding what organizations are dedicating their mission and vision to those next steps. So how do we achieve health equity? Public health professionals could enhance the impact of these strategies to reduce health disparities and disseminate and take these strategies to reach these vulnerable communities that we've discussed that are being impacted by these health disparities, especially by COVID, and determine how to expand these strategies for an even greater impact by applying these lessons for future efforts, research, and interventions. So what is health equity? Health equity is, especially in public health, it's really defined as achieving the opportunity that everybody has the opportunity to achieve their full health potential, regardless of their social position or their social determinant circumstances. So that could be applied in things like housing and social class. And so these health inequities are reflected in disparities such as length of life, quality of life, rates of disease, disability, severity of disease, and access to treatment, which is a highlight that we were just discussing that a lot of people don't really have. See here, there we go. So what programs or organizations are engaging in health equity in these next steps? The Native Connections Grant Program. This is a 5-year grant program serving American Indian and Alaska Native communities. And they are actually partnered with the Substance Abuse and Mental Health Services Administration. And what they really do is they focus on suicidal behavior and substance use and reducing that for youth. And then they ease the impacts of substance use, mental illness, and trauma in tribal communities. And they support youth as they transition to adulthood. It's important to understand that because they partner with the Substance Abuse and Mental Health Services Administration, they have 5 major priority areas. And a lot of that centers around combating the opioid crisis through prevention, treatment, and recovery. They address serious mental illnesses and emotional disturbances, and they try to have an impact in advance prevention, treatment, and recovery services for substance use. They also focus on data collection and strengthening education for communities. The National Organizations Against Disparity, they also attempt to eliminate disparities by coordinating community efforts and knowledge and training of cultural practices. They advance political will and they strive for partnerships for excellence. They leverage their resources and they focus on research and designing new practices and implementing them. Their vision is striving for behavioral health equity for all individuals, families, and communities, especially those who are underserved and who are really going through these health disparities we see today. And their mission is to build this network of diverse racial, ethnic, and cultural minority communities to promote these policies, these practices, and make health disparities not the norm or the standard.
Yeah, thank you so much, friends. It has been like a wonderful discussion. We have like, known the challenges, what's happening in our rural areas, what's happening in our healthcare access, whether people are healthy and all that. We have found a lot of disparities in our, like the racial and ethnic minorities. And that's not acceptable. We know that, but still, like, like we have to accept the reality and go ahead, like filling the gaps. And at least in the next decade, we just see, like some of these gaps are filled up. And especially I'm looking forward to filling up the children poverty, like because it's going to affect the future of us. So when we take health disparities, it's a nationwide problem, like that, like we have to, that includes many types and people of professionals. It's not one single individual who can do that, like some people can bring, a group can bring a policy and a program, and who is to execute, like there should be, like a network of professionals who really, understand, become aware of what's a problem in the society and how we do the social work to bring health for everyone. So even with WHO, the World Health Organization, health for all is, like is a common goal always with WHO, because they believe when you have health, like you're going to have good life and you're going to have a good society, and that builds a nation and that becomes a universe. So health is everything. So the challenge of eliminating that is actually an opportunity for all the social workers, the healthcare professionals, and also all of us individuals, the public health professionals, to meet the needs of the vulnerable and underserved populations. And we have to make a difference in our society, because we are consuming everything from our society, and we have the social responsibility to bring health unto everyone. Thank you so much.
Yay, go team. This is an amazing discussion, very insightful, and all of you just do such a great job on the presentation materials. I want to, before we hop off here, I'd love to highlight all of you. If you could just tell the audience your name, who you are, and what your role is.
Yeah, thank you so much, Cynthia. So my name is Indumathi Balasubramanian, Indu. I'm a public health, environmental health policy lead. So I worked with Assuaged for the past 1 year. It's a beautiful journey. It's a very positive space. Cynthia, it's always encouraging for us. I'm a medical doctor from India, a counseling psychologist. Like I did my environmental safety and health management here with University of Finlay. So I love Assuaged, like it's a great space to grow. We bring in a lot of discussions, public health discussions to people. like many people are like thanking us for bringing this awareness. Thank you so very much to Assuaged and Cynthia. Thank you so much.
Thank you. Uh, Ruchika.
Hi, everyone. So, my name is Ruchika Anand, and I am the social media lead at Assuaged. I have been managing the social media channel as well as the interns. And it's definitely, as Indu said, it's a beautiful space to grow. I've learned a lot in my last 1 year, and I have a major in bio. So, I can relate to all this because health is very, very important for us, and we should be taking care of our health as well as now after taking of our health we have to think about the society. We have to give something back to the society. So thank you so much for highlighting me, Cynthia.
Thank you, love. Lena.
Hi, everyone. My name is Lena Soleil. I currently have a bachelor's in the health sciences, and I'm getting my master's degree at Cal State Fullerton in public health. Um, and I have been an intern here at Assuaged for 3-4 weeks now. So it's been a great journey, and I'm learning to get accustomed with what the theme is and who the people are. And it's been a great journey. So I'm really grateful to be part of the Assuaged organization and today's live discussion. So thank you.
Thank you so much, Lena. Amazing, amazing team. So much fun. Vinotha.
Oh, hi, Cynthia. So, something about me, I'm Vinotha Subramanian. I'm currently a graduate student in Northeastern University. I'm here with Assuaged for about 2 months now. So, I'm really happy for the opportunity. I'm glad I met Cynthia, and I should really thank her for this. So, it's been an amazing journey. I've met a lot of people here. I've worked on different projects, and even the data team has been amazing. So, and everybody in Ruchika, everyone has been very supportive of everything, and we have a lot of interns coming into, and this is so really, really a happy and a colorful team. So, I'm looking forward to more of it, and please do visit our page. We have exciting products coming up. So, yes, so happy for everyone here. Thank you.
Thank you so much, Lovey. So exciting. Oh, Luna.
Hi, so my name is Luna. I'm a public health student at Northern Arizona University, and so I'm finishing up my last semester of my bachelor's degree. Um, I've been kind of all over the place as far as like my tasks and my roles here at Assuaged. I've been involved in the wellness program, I've been involved in HR, and then I've been involved in, I guess, just various public health topics. Um, and so I've had a really great time. It's only been, I guess, about 3 to 4 months now, and I've learned so much and gotten to, kind of just throw myself into all kinds of different tasks. And I think that's been really awesome. And it's been a great experience so far.
Thank you so much, Luna. Just yes, excellent. We're all on the back end. We're all like messaging each other how awesome we are. So it's just really exciting. And Nancy, I know your camera's not working, but would love to hear from you too, love, before we hop off.
Hi everyone, my name's Nancy. I'm bacheloring in health science, so it was really nice to be a part of Assuage. I am part of the public health. I'm an intern here. I'm really just starting to see how the organization works and getting to know all of you and how we're working together. And I just think it's beautiful, and I'm so excited to be here and part of the gang. Thank you.
Yay, you guys. That was such a informative, insightful session. And every week we are coming on to these live discussions and talking about public health. This Friday we'll be watching a movie, Seaspiracy. That's going to be really exciting because we have not done that before. So this is just kind of like life. We're always trying new ways of educating and advocating the masses on topics involving public health, as well as featuring our celebrity features. So thank you guys so much for just coming on here, joining our team, and enjoying everything that we have to offer. So yay. Thank you guys, and we will see everyone
Yay.
on Friday.
Yeah.
All right.
Thank you. Thank you. Bye. Bye.
Bye. Thank you, everyone. Bye bye.
Thank you. Bye.